definition of difficult to treat rheumatoid arthritis includes three main criteria. First, failure of two biological or targeted synthetic disease-modifying antirheumatic drugs with different mechanism of action. Second, having signs of active disease. And third, the disease being perceived as difficult to manage by the patient or rheumatologist. The third component is much harder to capture systematically, and that's part of the problem. As part of the Therapeutic consortium, we wanted to look at the evidence that is currently available for treating these patients. We systematically reviewed the literature and looked at three difficult-to-treat RA relevant clinical scenarios. First, patients with limited treatment options because of comorbidities or contraindications. Second, patients with persistent active disease after two biologic or targeted synthetic DMARDs. And finally, patients with poor health-related quality of life despite low objective inflammation, considered for non-pharmacological interventions. We screened more than 8,500 records and ultimately included 131 studies. But one of the key messages is that the evidence is still quite limited in several areas. We found a growing body of evidence supporting the safety of DMARDs and that they mostly retain their efficacy across a range of comorbidities, including obesity, cardiovascular diseases, previous malignancy, and respiratory disease.
Well, most biologic and targeted therapies showed benefit, even in patients who had already received more than two. Interestingly, our analysis suggests JAK inhibitors retain efficacy as treatment failures increase. But this needs to be balanced against the safety profile, particularly cardiovascular and malignancy risks. We need to be cautious in interpreting this because much of the evidence comes from subgroup analysis of trials with a high risk of bias. Trials don't usually include patients with difficult-to-treat RA. No, if they include patients with prior BTS DMARD failures, at a minimum, they should pre-specify patients who have failed at least two BTS DMARDs with different mechanisms of action for subgroup analysis.
This is actually one of the biggest gaps we identified. Studies on non-pharmacological approaches often don't report patients' prior treatment history clearly, making it difficult to know how applicable the evidence is to difficult-to-treat RA.
First, difficult-to-treat RA does not mean that treatment options have run out. There is evidence to support treatment choices even after multiple treatment failures, and also across a range of comorbidities. But decisions need to be individualized. And second, we need better evidence that is actually designed or targeted towards difficult-to-treat RA, the population of difficult-to-treat RA. The ultimate goal is to move from simply asking which treatment can we try next to asking what is driving the patient's disease and what is the best strategy for this individual.